Hello, my name's Will Blakeney, an orthopaedic surgeon working at Royal Perth Hospital and UWA. This lecture is on an introduction to the knee. We'll start by having a look at the anatomy of the knee, then a quick review of pertinent history and examination for knee pathology. Then we'll look at some common conditions and finally management of these conditions. We'll start with some case vignettes. This first case is a 25-year-old soccer player. She had a non-contact pivoting injury. She says she felt a pop and had immediate pain, and the knee swelled up within the next hour. She was unable to play on, and you see her 2 weeks later with the knee still swollen and painful. Second case is an 18-year-old footy player. He was jumping up to take a mark and landed awkwardly. You can see in the picture there how his knee is deformed. He's got extreme pain and he's unable to straighten the knee. Next case is a 75-year-old woman. She has a deep ache in the knee. Pain is often felt at night and affects her sleep. She has difficulty walking and has developed a limp. Lately, she's started using a walking stick to help her with mobility. She has no history of an acute injury, but the symptoms have gradually got worse with time. You can have a think about those 3 cases as we go through the rest of the presentation, and we'll come back to them at the end. First, we'll have a look at the anatomy of the knee to refresh your memory, as of course the anatomy is pertinent to orthopaedic injuries. We look at the bony anatomy. The knee joint has the tibia and femur with the tibiofemoral articulation, as well as the patella and the patellofemoral articulation. Fibula lies lateral to the tibia and has a proximal tibiofemoral articulation as well. We look at the ligaments of the knee. The 4 most important ligaments are the 2 cruciates, anterior and posterior cruciate, as well as the 2 collaterals, the medial collateral or MCL and the lateral collateral or LCL. Other important ligaments which you see pictured on the right, the medial patellofemoral ligament, which is important for patella stability. There are many other ligaments of lesser importance, but I won't go into them for the interest of time. Looking at the muscles of the knee now, the 2 main groups are the extensors and flexors. The extensor is the quadriceps, which is made up of these 4 muscles pictured. It then forms the quadriceps tendon, which inserts onto the patella. The flexors, also known as the hamstrings, are the 3 muscles pictured: semitendinosus, biceps femoris, and semimembranosus. As mentioned previously, the quadriceps muscles forms this quadriceps tendon, which inserts onto the patella. And then from the inferior pole of the patella, we have the Patella tendon, which inserts onto the tibial tuberosity. And this is known as the extensor mechanism, as it is key for knee extension. The iliotibial band and the patella retinaculum also contribute to its function. The menisci have an important role in improving articular congruency and increasing the stability of the knee. Their other role is in distributing load during movement. During weight bearing, about half the contact stresses are taken by the menisci when the knee is loaded in extension, and this rises to almost 90% with the knee in flexion. Thus, if the menisci are injured and removed, the articular stresses are markedly increased. Studies have shown that even a partial meniscectomy, taking 1/3 of the width of the meniscus, can produce a 3-fold increase in contact stress in that area. This is why partial meniscectomy or complete meniscectomy will often lead to early onset of osteoarthritis. Final role of the menisci is controlling the complex rolling and gliding actions of the joint as the knee goes from extension to flexion. As you can see in the picture here, the medial meniscus is a much larger meniscus and is less mobile than the lateral meniscus due to its greater attachments to the capsule. It is therefore the one that is most frequently injured. So when taking a history of knee injury, it's good to focus on the following symptoms. Firstly, pain, either acute or gradual onset, is the most common knee symptom. With inflammatory or degenerative disorders, it's usually a diffuse pain, but with mechanical disorders, and especially after injury, it is often localized, and the patient is more likely to point to a specific region of the knee. The mechanism of injury is always important. If the patient can describe if it was a direct blow, to which side of the knee, which way the force went, the surgeon can have a better idea of the type of injury. For example, a direct blow to the front of the knee is commonly seen with a posterior cruciate injury, whereas a blow to the side may lead to a collateral ligament injury, and twisting injuries are more likely to cause a cruciate ligament rupture or a meniscal injury. Swelling, which may either be diffuse or localized. It's important to know whether the swelling appeared immediately after an injury, which suggests a hemarthrosis, typical of a cruciate injury or meniscal tear, whereas complaint of recurrent swelling with normal periods in between suggests a chronic internal derangement, which you might see with inflammatory arthritis or an old meniscal degenerative tear or loose bodies. The location of the swelling is also important, whether it is intra-articular or extra-articular, and we'll look at that in more detail later. Stiffness is a common complaint and should be distinguished from inhibition of movement due to pain or simply weakness. Stiffness is classically seen in osteoarthritis, usually presents after periods of inactivity, such as first thing in the morning. Locking is different from stiffness. When we talk about locking, it means the knee suddenly cannot be fully extended, although flexion is still possible. This most commonly happens with a torn meniscus or a loose body caught between the articular surfaces. Patient may describe being able to manipulate the knee around to unlock it. Deformity, such as increasing varus or knocked knees, may be noticed by the patient. Giving way or instability normally suggests a ligamentous injury, but it could also be a meniscal or capsular injury or simple muscle weakness. We should also distinguish from giving way as a result of pain rather than instability. Limp may be due to pain, instability or deformity, and an antalgic gait may also be caused by a pain referred from the hip. Loss of function usually manifests as a progressively diminished walking distance, inability to run, difficulty going up and down stairs. Squatting and kneeling may be painful, either due to pain from pressure on the patellofemoral joint or because the knee cannot flex fully. I won't go into too much details about examination, as this is covered in your clinical skills teaching. But again, the simple look, feel, move and special tests of the orthopaedic examination: observation, active and passive range of motion, resisted muscle testing, and then palpation and special tests. Patient should be observed standing as well as lying down. Here you can see typical varus and valgus deformity. Gait is important to be assessed as well. Patient should be observed walking with and without any support, such as a walking stick. During the stance phase, it should be noted whether the knee extends fully or whether they have a fixed flexion deformity or a hyperextension deformity, as seen here, pictured here, with procurvatum deformity of the knee. Any lateral or medial thrust during stance phase should also be observed, and during swing phase should be noted whether the knee moves freely. Special tests in the knee can be broken down into these four main groups. Tests for intra-articular fluid, such as the swipe test or patella tap. Then there are specific tests to assess the patellofemoral joint, particularly whether it is tracking normally or whether there is apprehension. Tests for stability, most importantly the test for collateral and cruciate ligaments, and then finally tests for meniscal injuries. The McMurray's tests are the most commonly performed. Differential diagnosis for anterior knee pain is presented here. Patellofemoral disorders include patellar instability, patellofemoral overload, osteochondral injury, or patellofemoral osteoarthritis. It could be disorders of the actual knee joint, including osteochondritis dissecans, a loose body in the joint, synovial chondromatosis or plica syndrome, periarticular disorders, including patella tendinitis, patella ligament strain, bursitis, or Osgood-Schlatter's disease. Finally, don't forget that knee pain can be referred pain from the hip. Pictured, you see a patient with an acute left knee swelling. Swelling which is immediately after an injury usually means there is blood in the joint or a post-traumatic hemarthrosis. The knee is very painful and feels warm and tense. Movements are restricted. X-ray is essential to ensure there is no fracture. If there is no fracture, then other possibilities are an intra-articular ligament injury such as ACL or a meniscal tear. Patients that have coagulation disorders will commonly present with an acute bleed in the knee. Acute septic arthritis is an orthopaedic emergency and requires prompt treatment to prevent both systemic spread and avoid local damage to the knee. Patient normally has extreme pain on the movement of the joint. Inflammatory markers are elevated, and aspiration will reveal pus in the joint, which, when sent for microscopy, will demonstrate a high white cell count. Bacteria may be seen. Treatment consists of surgical drainage and irrigation of the joint and intravenous antibiotics. Traumatic synovitis is where an injury to the knee stimulates a reactive synovitis. Acute swelling of the knee without a history of trauma or signs of infection suggests gout, pseudogout, or an inflammatory arthropathy. Aspiration of the joint will demonstrate crystals in gout and pseudogout, and treatment is with anti-inflammatory medications. Chronic swelling of the knee can be either an intra-articular process or a bony swelling. The commonest cause of chronic swelling is either an osteoarthritis or an inflammatory arthritis, such as rheumatoid. Should also consider synovial disorders, such as synovial chondromatosis and pigmented villonodular synovitis, or PVNS. Diagnosis is usually obvious from an MRI scan, such as pictured here, and can be confirmed with a synovial biopsy. Because the knee is a superficial joint, bony swellings of the distal femur and proximal tibia are often visible and palpable. Some common things seen are osteochondroma, which is a cartilage-capped exostosis, Osgood-Schlatter's, which you see pictured on the X-ray here in clinical photo, is a characteristic painful swelling of the tibial tubercle, which usually presents during adolescence and is often self-limiting. And malignancy, although rare, should always be excluded. Prepatellar bursitis, also known as housemaid's knee, is a fluctuant swelling which is confined to the front of the patella and does not involve the joint itself. It's usually due to recurrent friction between the skin and bone. It's often seen in workers that are often on their knees, such as pavers or carpet layers. Treatment consists of firm bandaging and avoidance of kneeling. Occasionally aspiration is needed. In chronic cases, the lump may need to be excised, and secondary infection is not uncommon and requires antibiotic plus or minus surgical treatment. Pictured on the right, you also see the infrapatellar bursitis, which is a similar condition but affecting a bursa is more inferior to the knee. Occasionally other bursae are involved, such as the bursa deep to the patella tendon or the pes anserinus bursa. Posterior knee swelling, most commonly bulging of the posterior capsule and synovial herniation may produce a swelling in the popliteal fossa. It is usually seen in the midline and generally presents in older people with osteoarthritis. It was originally described by Baker, hence Baker's cyst. Occasionally the cyst ruptures, which will cause pain in the posterior calf. Semimembranosus bursa is the bursa between the medial head of gastrocnemius and semimembranosus. Can become enlarged and usually presents as a painless lump behind the knee, slightly medial. It's normally self-limiting and will resolve with time. Any pulsation in the lump should make you think of a popliteal aneurysm, which is the commonest limb aneurysm. A thrombosed popliteal aneurysm doesn't pulse, but it does feel almost solid rather than fluctuant. And if we go back to our first case, this is the typical presentation of anterior cruciate ligament injury. You can see a ruptured ACL pictured here. It's the most common knee ligament injury and is often ruptured playing sports, typically pivoting sports such as football, netball, rugby. Commonly occurs when suddenly changing direction or landing and twisting from a jump. The ACL's main role is to limit forward movement of the tibia on the femur, but it is also important for rotational stability. It is very rare for the ACL to heal satisfactorily on its own. This is because the synovial fluid present around the ligament is thought to prevent formation of a consolidated clot that is required to promote a healing response in the ligament. In some individuals, however, the knee can stabilize symptomatically and clinically after a period of appropriate rehabilitation. Clinical examination will demonstrate a hemarthrosis. The anterior draw test and Lockman's test, which is pictured here, are tests in which the examiner displaces the tibia anteriorly in relation to the femur. The pivot shift test is another test which demonstrates the rotational importance of the ACL. Diagnosis is confirmed with an MRI scan. On the left you see the normal appearance of ACL versus a ruptured ACL on the right, where there's no continuity of the fibres of the ACL. Here is the arthroscopic appearance of an intact ACL versus a torn ACL. The treatment of an anterior cruciate ligament depends on age and activity, but as a general rule, in younger patients under 22 tend to reconstruct. Nearly all comers. The ages 22 to 35 depends on patient's level of activity, but again, more commonly we tend to reconstruct. And then any patients over 35, we try to treat non-operatively unless they're having ongoing instability, either at work or with sport. ACL deficiency can be overcome with a specific ACL rehab program. The main focus is quadriceps rehabilitation and conscious control over the knee to minimise the sagittal and rotational instability. This can allow individuals to return to sport. However, the potential remains for future pivoting instability, which can cause subsequent damage to the chondral and meniscal surface of the knee, which are irreversible. The surgical treatment is ACL reconstruction. This is done arthroscopically, most commonly using hamstring tendon autograft harvesting, as pictured here on the left. Other graft choices commonly used are the Patella tendon and, to a lesser extent, quadriceps tendon. It is a common orthopaedic procedure with a good success rate. The most common complication, however, is re-rupture of the ligament. This is reduced by diligent post-operative rehabilitation, as well as delaying return to sport until 9 to 12 months post-surgery. Meniscal tears are often seen in the context of an ACL injury, but can often present on their own. Pictured are the different types of tears that we commonly see. Some are more conducive to surgical repair, where others, the only option may be debridement or partial meniscectomy. As mentioned previously, the meniscus has an important role in distributing load during movement. So if at all possible, we try to preserve the meniscus to avoid subsequent development of osteoarthritis. Meniscal surgery can be divided into repair, which you see pictured on the left, versus partial meniscectomy or debridement of the tear to a stable base, as pictured on the right. Surgery is indicated if the patient has mechanical symptoms, that is locking or catching, which is recurrent and not settling with non-operative treatment. If the joint is locked and cannot be unlocked, this is an indication for a semi-urgent operation. In patients with osteoarthritis and degenerative tears, surgery should be avoided where possible and conservative treatment employed. Looking back at case 2, what you can see pictured here is a patella dislocation. It is important that you understand the difference between a patella dislocation, which is the kneecap which is dislocated, and a knee dislocation, where the dislocation is of the tibia on the femur. You can see the two pictured here. Patella dislocation has some predisposing factors: generalized ligamentous laxity, underdevelopment of the lateral femoral condyle, and flattening of the intercondylar groove, or also known as trochlear dysplasia. Maldevelopment of the patella, which may be too high or too small, can be associated with a valgus deformity of the knee or an external tibial torsion. And finally, it may be a primary muscle defect. Patella dislocation is extremely painful, so urgent reduction is the first step of management. Following that, reduction of swelling using ice compression, elevation and rest. Then regaining range of motion of the knee, followed by muscle strengthening exercises. Physiotherapy is directed towards closed chain exercises of the vastus medialis oblique, or VMO. This is the main stabilizer of the patella, so attempts are made to strengthen it as much as possible. You can see in the picture the technique used for reduction of a patella dislocation with a force from lateral to medial. Combining this with extension of the knee will result in the patella indicating with satisfactory clunk. This video demonstrates a dislocated patella in the leg in a typical flex position, lateral to medial force, whilst also extending the leg allows the patella to enlocate, and then the leg is able to be fully extended. First-time dislocators are generally managed non-operatively, but in 15 to 20% of cases, the first episode is followed by recurrent dislocation or subluxation after minimal stress. This can be treated non-operatively with physiotherapy, again, isometric quadriceps strengthening, focusing on the VMOs. Patient can wear a knee brace initially, but we try to avoid it long term, as the knee brace will often lead to quadriceps wasting. Patella taping, as pictured here, may have some success, but has mixed results in the literature. There are many different operations described for recurrent patella dislocations. The general principles are, firstly, to repair or reconstruct the medial patellofemoral ligaments. Other options are to realign the extensor mechanism so as to produce a mechanically more favourable angle of pull. Here you see pictured a tibial tubercle transfer. And finally, occasionally it's required to treat the trochlear dysplasia if this is present and predisposing to instability. Most common operation performed nowadays is the MPFL reconstruction, using a hamstring tendon to reconstruct the torn ligament. If we look at the final case in our series, this lady has the typical presentation of osteoarthritis. Of the large joints, the knee is the commonest to have osteoarthritis. There's often a predisposing factor such as injury to the articular surfaces, a torn meniscus, or ligamentous instability can be associated with the deformity of the hip or knee. However, in many cases there's no obvious cause, and it may just be a genetic predisposition to the condition. It is a disease of older age. Obesity has the strongest association with osteoarthritis of the knee than other joints. Pictured here you see a radiograph of a normal knee and then a knee with medial compartment osteoarthritis. Again, the 4 cardinal radiographic signs of osteoarthritis are loss of joint space, osteophyte formation, subchondral sclerosis, and subchondral cysts. Initial management is non-operative, activity modification, weight reduction, using a stick or walker, physiotherapy and anti-inflammatories. Intra-articular cortisone injections are also commonly used with good effect in the knee. Operative treatment is knee replacement for end-stage disease that no longer responds to conservative management. Knee replacement is the most common joint replacement performed in Australia with excellent long-term results. Knee replacement can be either a total knee replacement or a partial knee replacement. Unicompartmental knee replacement, pictured on the right here, is used in this case where the patient has osteoarthritis which is confined to the medial compartment. It has the advantage of preserving the knee ligaments so that patients often feel their knee has a more natural feel to it. However, if the arthritis progresses to the lateral compartment, it may need to be revised to a total knee replacement. So these do have a higher revision rate than total knees. Hope you enjoyed the presentation, and if you have any questions, please feel free to get in touch.